Good evening, and thank you for joining us for this special show on cancer care powered by Rosh. I'm your host, Anisha Nayar Dhawan. In this special series on cancer care, we shall be turning the spotlight on the rising incidence of cancer in India. We'll understand the various aspects and nuances of different kinds of cancer and speak to experts to know if people can reduce their cancer risk. On the show today, we are going to talk about breast cancer, early detection, screening, and diagnosis. Now, 1 in 10 Indians will develop cancer in their lifetime, and 1 in 15 will die of it, according to the World Cancer Report released by the World Health Organization, WHO, in 2020. The sharpest rise in cancers is of the cancers of the breast, the colorectal, and we are seeing a decreasing rate of cervical cancer. So the cervical cancer rates are falling, but those of cancer and of breast cancer and colorectal cancer are on the upswing. Now, post-cancer survival for women with breast cancer in India was reported at just 60%. When you compare it, it's as high as 80% for some of the Western countries like the US. Now, some of the factors that lead to this could be late diagnosis because of ignorance, detection of aggressive forms of cancer in younger women, which is higher in India than the rest of the world, and of course, the numerous hurdles in the access to the healthcare because of high costs. Now, advancement in cancer treatment has brought about a sea change in the lives of breast cancer patients. But the truth is that the treatment are most effective if the disease is diagnosed early on. So, early diagnosis is critical to determine the outcomes in breast cancer patients. Is it easy to detect breast cancer early? What explains patients coming for treatment in advanced stages in India, which is a large majority? Are there screening programs which are recommended by the government, which are running in our country extensively? Is there enough awareness about this in our country? To discuss this and more, we have a panel of experts. Please welcome Dr. Roshni Dasgupta, medical oncologist, HCG Cancer Hospital, Bangalore, and Dr. Srinivasa, BJ, medical oncologist, HCG Cancer Hospital, Bangalore. A warm welcome to both of you. Thank you so much for sparing the time to come on our show.
Thank you.
So let me start with you, Dr. Roshni. Could you tell us what is considered early detection of breast cancer?
As you have very rightly introduced the whole aspect of breast cancer, the stage, the awareness, the importance of early detection, and the availability of facilities, but probably less than expected usage of the same. So to define what exactly early detection of breast cancer is, it is to have a breast cancer detected at a stage where it is curative, where the intention of the treatment will be curative. So any cancers is staged by the AGCC as a stage 1, 2, 3, 4. Stage 1 and 2 is considered as the early breast cancer. This is when it is best to detect the cancer and the cure rates are very high, with very less lifetime recurrences. Stage 3 is called locally advanced, but still they are curative. It is the stage 4 metastatic, which is the most advanced stages of the cancers. At this stage, it is not curative anymore. It is more of controlling the cancer. So early stage is stage 1 and 2, and some cases of stage 3.
All right. So, Dr. Roshni, you've explained it in the medical terms that stage 1, stage 2, and perhaps some cases of stage 3 are curable, and that is what is early diagnosis of breast cancer. For the patient, what does it mean? When you feel yourself and you feel a lump, could it be stage 1, stage 2, or is beyond stage 1, stage 2? For the patient, how can I be diagnosed as early as stage 1, stage 2?
So early stages usually presents as a painless lump of the breast. It might present as a unilateral nipple discharge or the change in the skin texture of the breast. It might be present as an immobility of the breast, difference in the contour between the two breasts. These are the usual symptoms which are usually present and can be detected by the person herself by a simple breast examination and make use of for the early detection of cancer.
All right. Dr. Srinivasa, what is the right age for women to start tracking their breast health or do the self-exam? Because In Western countries and otherwise also, cancer is seen as a disease of aging. And in the Western countries, the majority of the women who have breast cancer are generally in the 50th or the 50th or the 60th year. So in India, what's the best time to start, self-examining and, becoming aware?
Yeah. So, in addition to this stage 1 and stage 2, we have screening detected breast cancer also, where before a patient or any doctor could feel any lump in the breast, the mammograms, the screening mammograms, they can detect the breast cancer as early and it is almost curable, almost 100% curable. So there, the patient also doesn't feel any symptoms, doesn't feel any lump. So usually, as you rightly told, usually in the Western countries there is a particular screening program put by the government. But here we don't have any such rigorous screening program for breast cancer, including all the states. So usually, if there is any no risk factors in their family or for the patient themselves, there is no high risk factors. So usually by the age of 45 years, they can start doing this breast health examination. They can start by their self breast examination or screening mammogram. If there is a high risk factors like family history is there, or any like a family history of that BRCA mutations, we call it as a hereditary breast cancer. So then they should start as early as possible by 30 or 40 years of age.
Dr. Srinivasan, you mentioned that early breast cancer stage 1, stage 2 can be detected by screening. Were you talking of cases in India, or are these cases in Western countries? Because there they
That's
have
what. That's what these stage 1 and stage 2. That is the difference between the Indian and the Western population. So the incidence wise, if we consider the breast cancer incidence is very less in India compared to the Western countries. But we take the example of death by breast cancer is high because most of the women, because of their social embarrassment or the neglect, they come in the advanced stage of disease. So most of our Indian breast cancers are detected by the either the medical examination or when the tumor has grown too big and the patient and the disease has advanced. So this screening breast cancer screening breast cancer detection is more common in Western countries, not in India. So we have to make ourselves educated, our relatives, our public. We have to educate them that they should undergo the screening at the age of 45 itself, or any risk factor is there to undergo as early as possible to detect the screening detected breast cancer. That's what I.
Okay, so if I understand right, Dr. Srinivasan, you're saying that there is no recommended or as a rigorous screening program running for breast cancer in our country. And that could be one of the reasons why women present late. But you also said that there is a stigma attached to breast cancer and women tend to hide it. And that is why when they come, it's so late, because at that point of time, the discomfort is there. And it's not something that is easy to hide. So, Dr. Roshni, what does it mean to have early breast cancer? And what prevents women from seeking care, in early stages of breast cancer? Because now we have, tertiary care centers also where some, the healthcare access, an attempt is being made to improve it.
Rightly said. Actually, there is National Cancer Control Program going on in India. They have put in a lot of resources to make people aware of breast cancers, as well as they have arranged training as well as mammogram screening for female in regional cancer centers. Of course, there is a high discordance between the urban and rural population when it comes to that, because regional cancer centers are usually situated in one of the metropolitan cities. To start with, why early detection is a problem in our countries, first of all, one of the most important point to be highlighted is lack of awareness. And of course, when I say lack of awareness, still I would say on the positive side, urban population is slowly becoming more aware of breast cancer, and more women are coming up for breast screening programs. But unfortunately, in rural India, it is still a stigma. In fact, they're unaware of breast cancers, unaware of any kind of cancer. And when it comes to social stigma, it is known that in our country, women as such neglect their health, whether be it cancer or any other. And breast being, symbolized as a sexual organ, females usually are not free enough to discuss about any problems related to the breast. Uh, women are not only afraid of discussing regarding the breast uh, as a structure, as a organ which can have problems and diseases to which treatment can be given. At the same time, people are scared of cancer. Like, what if I have cancer? If I go to a doctor will detect the cancer, then what? It's the fear of cancer itself and the treatment for cancer. So lack of awareness of breast cancer, to the from diagnosis to the treatment, everything encompasses two factors, and why women in our country do not come up for breast screening programs.
Okay, so you have listed many socio reasons, societal reasons why women are not coming in. But Dr. Roshni, other than that, are there any access concerns also that you think inhibit? Because one thing is, I have a problem, I will get it diagnosed, but then how will I get it treated?
Yeah.
It's a burden. Some women also think like this: my job is only to serve my family. How can I be a burden on my family? So is access also a problem?
Yes, access definitely. As I said to you, that even if the government has put in the resources for the screening program development, it is still very restricted to few centers, few cities in the regional cancer centers. The screening program, the network has to infiltrate from one level to the other. Like when I talk about rural India, primary care physician, the ASHA, the auxiliary nurses, they should be aware of that where should the patient next go to if they suspect a cancer in their breast, where should the patient go to? That network, that accessibility is a hindrance, definitely.
But you are saying that there is some sort of screening program that has already started. So, Dr. Srinivasan, are there any risk associated with breast cancer screening? And are you aware of what should work best? I mean, what is your opinion about breast cancer screening in our country? Should we follow the Western model? Have mammogram machines in every district and get women to those districts and then screen them? Will that work?
Yeah, I mean, risk of breast cancer screening as such, there is no major risk actually. So there were some concern about exposure to radiation every 1 year or every 2 years. But
screening, you're talking about screening by mammograms.
Mammogram, screening by mammogram. So, as such, there is no major threat if the patient, I mean, the people will get screening. So, usually estimated exposure to radiation is only 0.4 millisieverts. Sieverts. I mean, if we compare to natural exposure per year, it will be almost 3 years for the general population for the one individual. So it's very less for both the breast combined. It is so except the pain, some pain during the procedure. Apart from that, they don't have any risk associated with screening mammogram. And you told about whether we should put a rigorous timeline or rigorous age. Yes, I think we should the government should set up every district should have this screening mammogram, like we have the regional centers. So we should encourage the primary care physician or primary care paramedical personnel so that they should be aware of this and they can take forward further. I think most probably. I mean, screening mammogram has definitely shown that it can reduce the death by breast cancer. So we should encourage.
And how often, if a program is to screen by mammogram, how often do women go for
once in 2 years? If there is no higher risk. Yeah, once in 2 years, if there is no high risk factors, or once in a year, if there is a family history of breast cancer, after the age of 45 to 50 years, they should start.
Okay, 45, 50, either once a year or twice a year. Dr. Srinivasa, do you think this is going to be a practical solution to our problems? Because, what we are seeing in our country is that more of younger people are being detected with breast cancer because the age profile in our country is also slightly lower than what it is in Western countries. Now, when you're older, perhaps a mammogram is more effective in imaging. At a younger stage, your breasts are dense. What is the chance that a mammogram will miss your tumor? Plus, it happens once a year. What if the cancer starts growing soon after my mammogram happens? Do you think this is going to be a practical solution?
Yeah, usually younger women always they have the family history and any genetic mutations going through that. So most of them they have that family history. So that's why the mammogram is, as you told, less than 40 years, denser breast, the getting the screening mammogram detected breast cancers are less. It is very difficult to get the breast cancer detected. So usually this applies to, because the younger population is usually in the Western population, it is more than after 50 years only. So we should start by 40 or 45 years. I think that is good enough, because most of the menopause will start by 45 years in Indian women, average Indian woman actually.
Okay. Dr. Roshni, Dr. Srinivasan has also mentioned that there is a high risk group, and this high risk group is the one that could have a genetic history of breast cancer in the females of the family. So does one need to worry about breast cancer if it runs in the family? Are they more likely to get breast cancer? And what should they then do? Just sit and fret all their lives? Oh God, I'm going to get it. Then what? What steps should they take so that they are proactive but not stressed?
Just to add to the previous question also, I'll come to your question this time. As WHO says that, see, relative risk reduction of any breast cancer related mortality, screening mammography is the ideal modality. Okay. Clinical breast examination as well as self breast examination does not reduce the breast cancer mortality risk. So, however, WHO also recommends like self breast examination from the age of 25 is important for breast cancer awareness. And clinical breast examination also should start at an early age of 30. Albeit it will not reduce the breast cancer mortality risk, but all these steps create a breast cancer awareness, and women can come to us at an earlier stage.
Okay.
That is one. And that is coming to the familial history and hereditary breast cancer syndromes. So first and second degree relatives, when I say first degree relatives, it is my children, my parents, and my siblings. If a hereditary cancer runs in the family, and ideally, if any of one of the member have been tested for the gene, for the pathogenic variant which has been causing this cancer, the first and second degree relatives should undergo the same genetic testing. Okay, this is usually done after they turn into an adult, after the age of 18. If the known genetic variant is known, and ideally, this test should be first performed in the family member who had the cancer. Okay, and once a detection has been done, if the person is a carrier of a pathogenic variant of the gene, then screening modalities are two. One is mammogram as well as MRI. So MRI starts from the age of 25. MRI breast in hereditary cancer with the BRCA gene carrier or any other high-risk genetic carrier, the MRI begins at the age of 25 years. The mammogram, despite dense breast, begins at the age of 30 years. And it has to be an annual MRI and annual mammogram staggered. So every 6 months, we are having a breast screening either with the MRI or a mammogram. This is to prevent the interval development of any cancers. So if there is any hereditary cancer risk, one should go and go for a session of genetic counseling, meet experts, and get the genetic test done. It's a simple blood test, often can be done from a saliva, from a buccal swab. So instead of staying in fear, it is better to get it genetically tested so that the further step surveillance program can be tailor-made for that person.
Right. Dr. Roshni, you spoke about first degree relatives. What if my Masi had a breast cancer? Or, or a cousin has had breast cancer? Is my risk higher?
Yeah, your Masi becomes a second degree relative. So for first and second degree relatives should test. Your cousins become actually third degree relatives. So third degree relative is not always at, they have a 25% risk of carrying the gene, but a first and second degree have a 50% risk of carrying the same gene running in the family. So first and second degree definitely should test.
Okay, but you are saying that the person who has been diagnosed with a cancer should undergo this testing to see. I think they undergo this testing so that the treatment is then also, decided for them, right?
There are certain criteria that guide us where whom genetic testing is going to be relevant. So there are very strict some criteria like a very early age, less than 45 years of age. Any woman with a breast cancer should undergo a genetic testing.
Okay.
Then strong family history. Then there are not only just breast. If there is ovarian cancer, one should go for a genetic testing. Males in the family might have a metastatic prostate carcinoma. They should go undergo genetic testing. Bilateral breast carcinoma, primary in a single individual with one of the cancers happening before the age of 50 should undergo genetic testing. Then there are types of breast carcinoma, like the triple negative, one of the most aggressive form of breast carcinoma. If that happens below the age of 60, they should go for a genetic testing. These are the few criteria which usually guide us. But then again, if you have a very strong family history with a first and second degree relative with any kind of cancer, leukemia, prostate, a lot of cancers in the family, clustered in a family from one side of the family, they should undergo a genetic testing. And very rarely, very not relevant in our country, but very theoretical. But yes, there are certain Ashkenazis Jews, as we say, they should go undergo genetic testing because their hereditary cancer risk syndromes are very high. So there are some certain criteria that we stick to when we go for a genetic testing.
Dr. Srinivasa, would you like to add on this? Because, Dr. Roshni has expanded the types of cancers within the family. Now, what used to happen, say, about a decade ago was cancer was very hush-hush, any type of cancer, because the incidence was not reported to be very high. But now in our country, I don't think there's any family who is untouched by cancer. If not immediately, some of the extended family members have had cancer. So then, I mean, who all should start, start this genetic testing? And how do you access genetic testing?
I mean, when we should start ask for
No, I'm saying who all should, because now nearly every family would have some or the other cancer case, and I'm not sure if you have a different type of any kind of cancer. Do all cancer patients go in for genetic testing to find out if this is something that runs in the family? So if there is a cancer case in my family, should I go for the genetic testing? And if I do want to go, where should I go for genetic testing? Because I don't have cancer.
Okay. So any cancer, familial genes, what we were mentioning about BRCA mutation. So it carries the risk of almost 25 to 50%. So when there is no familial genes detected, so usually there is a 20% risk of any family members getting that genetic cancer. I mean breast cancer. So usually that's what I think my colleague already told that. I mean, any patients less than 50 years of age in the family, we should always do the genetic testing, especially if it is a breast and ovarian cancer, or if it is the prostate cancer in the family. So those cancers, suppose patient in the family has a head and neck cancers or lung cancer. Usually those they don't run in families actually. So it is almost 90% is related to the smoking or the tobacco chewing. So we don't recommend genetic testing for those patients. Even if you take the example of gastric cancer or take the example of gallbladder cancer, we don't recommend genetic testing unless there is a family history running in that family. So usually the breast cancer, ovarian cancer, endometrial cancer, or the prostate cancer in the males, those patients only we recommend strongly the genetic because the familial genes are known to run in the family, and the members, siblings, or the family members are at risk of getting the cancer. So where they should go? So there are so many genetic counselors are available, especially the regional cancer centers and all the corporate centers. Yes, in the rural setup, definitely we don't have anything there. But yes, most of the people, if they need to have the genetic counselors are available almost all the especially the tertiary care centers, I think most probably.
All right. So genetic counseling is possible for most people, actually, I think, in the metro cities, and that's a plus point. But thanks for clarifying which are the cancers, if they run in your family, should you be aware of to seek genetic testing. Dr. Srinivas, in your practice, have you seen that women are self-aware? Why have we not been able to make breast self-examination a practice among, at least the vulnerable section of women? Do you think this is something that women are doing?
Yeah, I mean, yeah, I think we should educate about this self-breast examination. So, as my colleague already told, that self-breast examination or clinical breast examination doesn't decrease the death by breast cancer as the screening mammogram will do. But definitely, we should create the awareness of breast cancer. They should know about their breast, the lump, what are the changes is happening, so that they can notice early and they can come to the medical attention. So I think yes, in our clinical practice we always see most of the women they neglect almost 6 months to 1 year before coming to the medical attention. Though they notice the breast lump, most of the women believe that any cancer is painful, so that's why they don't tell to their family members, or they don't come to the medical attention. So that is a common myth actually. Cancer is always a painful. So, but in the breast, that doesn't holds good. So, in the early stages, breast lump is always painless. So, only it goes to advanced stage, then only it becomes it is a painful. So, I think and why most of the women they don't do, they fear of the cancer detection, what should be done, all those things, all the dilemmas, all the and once again they sometimes fall positive. Even the all the tumors which are detected by the self-examination or self-examination are not cancerous. We have a fibroadenoma, which is a benign tumor. It is not cancerous. So some of the women they may have that. So it will create a little bit anxiety till they get investigated. So I think that's why some of the women they don't go for this self-breast examination. But it will just definitely we should encourage them to go for clinical breast examination by a medical personnel or self breast examination, so that they know about that, they know about the awareness about the cancer.
Right. Dr. Roshni, what have you seen in your practice? Because you're in Bangalore, it's a metro city, and now many corporates have this annual executive checkup for their senior employees as well. Most of the employees they do. So do you think if the women executives are undergoing, annual checkup, where they do get a pap smear done, and numerous tests are done. It may not be a mammogram. I don't think a mammogram happens in an executive checkup, whatever be the age, and may not even include a clinical breast examination. Do you think women who are taking charge of their health are breast self-aware? Have you seen this in your practice?
Very truly speaking, I would highlight 2 points. One is one of the most missing link in breast cancer awareness, as well as encouraging breast self-examination or clinical breast examination, is incorporation of gynecologists. Women in some point of their life do always visit a gynecologist. How many women do you actually see visit an oncologist or a general surgeon unless and until they have something that needs to be treated? But they always go to a gynecologist for some problem, for some woman-related health. So if the gynecologists and obstetricians start encouraging women for breast examination, if they are also trained and do the clinical breast examination, I think the early detection rates will go higher. And an organizational setup like the executive health checkups that actually they do not incorporate mammograms. In my experience, I have not actually seen women who do not have a family history to come forward and do the screening mammograms. Even if they are aware, they don't end up doing it. Unless and until they have a family history. So I have seen patients being detected with a breast cancer, and then her daughter's friend, they would come up for the screening mammograms after that. But very rarely have I seen women with no such histories in the family to come up and get a screening mammogram as it is usually recommended.
And you're saying that, like senior executives, they're 45, 50 years of age, they still have 10 years of, work to do, etc. Even they are not coming up for screening on their own, even if they know that, their risks become higher. It is recommended to get a screening done, even if your company doesn't pay for it. You think these people don't generally come for a screening?
Very rarely, unless they have a family history.
So could you give us some percentages of all the breast cancer patients that you've seen? How many have a family history? Is it only your genetics that dooms you to have breast cancer?
The family history actually makes women more aware. If someone in the family gets a cancer, they are somehow more aware. The awareness programs are highly lacking in our country. That's where we are failing.
No, that I understand. That once somebody in the family has cancer, your alarm bells are off. But what percentage of breast cancer cases are because of a family history? Aren't there some?
Actually, it's handful. It's only 10%.
Only 10%.
Only 5 to 10% is hereditary cause of breast cancer.
And 80 to 90% is no hereditary cause. And yet women in 45, 50 don't come and say, please let me do a screening.
No. That's the lack of awareness, and that's where we are failing.
That is why we are making this attempt, that we speak about this and tell people that please don't sit back thinking that I don't have any history of breast or prostate cancer in my family. I'm 45, 50, I go for an annual checkup, but I don't need to get this done. This is our endeavor to make people aware.
Yeah, sorry to interrupt. Yeah, yes. So that is one of the one more common myth. So no one in our family is having cancer, so me getting cancer is very less. So that is one more myth. We have to bust it and we have to create awareness. So only if you take 100 people, only 5 people will get the hereditary breast cancer, 5 or 10 people where the familial gene will run in the family. So most of the 90% it will be the hormone related changes which the patient will get: obesity, the environmental risk factors, food they eat. So we don't be able to pinpoint which is the more commonest cause. So that's why we should create the awareness about this. So I mean, one more thing, that painless lump I have told, no. So most of the people will believe that it is painful, so that they don't go early to their the awareness. I mean,
Dr. Srinivasa, could you please elaborate a little more about the risk factors? Are you talking, like you said about hormones, etc. Are these risk factors? What does it mean for an everyday person? I mean, 45 and above or 50 and above, women hitting menopause have higher risk. What does it mean for a regular person?
Yeah, usually there are established risk factors which are modifiable and which are not modifiable. Age is a non-modifiable factor. So after the age of 50 years up to 70 years, there is a steep increase in the incidence of breast cancer, and after 70 years it falls further. In the modifiable, in the non-modifiable factors, the menstrual cycles. So this is a relative risk. Early age of menstrual cycle, early onset of menstrual cycle, suppose 8 to 10 years, or late onset of menopause after 50, 55 years. So they are exposed to more to hormones, so they are at risk of getting more breast cancer. These are the relative risks. These are not the absolute risk factors. And the woman in their lifetime doesn't have children, that doesn't become pregnant, so they are also at risk of the breast cancer, because in most of their lifetime they are exposed to the estrogen hormones. When they have pregnancy, the estrogen hormone comes down during that period, and progesterone is more, so the exposure to the estrogen hormone is less during that period. That is why there is a relatively increased risk when the person doesn't get pregnant or have children during their, or don't feed their feed their babies also. They are at a risk. These are all the relative risks. They are not absolute risk factors, but relative risk, they may slightly increase the risk of breast cancer. Coming to the modifiable risk factor, obesity. So the most of the reports have shown that not only the breast cancer, endometrial cancer, prostate cancer, colon cancer, so many cancers they related to the obesity. So the breast cancer is not an exclusion. Physical activity, WHO recommendation is weekly at least 5 days in a week, at least 45 minutes a day. They should have a regular exercise to keep their, though even they are lean, they are not obese, they should have the physical activity. Sedentary lifestyle definitely have a risk, and should have the should have a balanced diet, and weight. If there is a, smoking also is a risk factor in women. Smoking and alcohol definitely, the reports have shown that they are at higher risk of getting the breast cancer. So these are, we call it as a modifiable or non-modifiable risk factors, which modifiable are in our control. We can take control of that.
All right. So, Dr. Srinivas, if I am a person who has not had a very healthy lifestyle because of my work, my family responsibilities, I'm not exercising even 5 times a week, and I eat a lot of fatty food. I'm obese also. So, after what age should I, go for screening, and what should be the screening? Should I go to the gynecologist and tell give me a CBE now, or I should just move on to a mammogram every year or every 2 years? What would you recommend?
Yeah, not maintaining the ideal body weight, or not following the physical exercise. It is not only the risk factor for only the cancer, for any other like non-cancerous disease like hypertension, diabetes, so many other disease it may we can invite. So this maintaining the ideal body weight and the reducing the weight or having the balanced diet is for all, as a health for all, actually, to make ourselves physically fit. So, for the breast cancer, especially if not following obese is there, I think definitely it is applies to the same. More than 45 years, because earlier less than 40, always it is a dense breasts are there, we cannot detect, or self breast examination should be done. There is nothing like that. You have not done physical activity, so you should do early. It is nothing like that. Nothing sort of that actually.
Okay, but after 45, mammogram is recommended, right?
Yeah.
Okay. Dr. Roshni, the treatment of breast cancer patient, depends a lot on the stage of the disease. Still, the awareness about first level screening is so low. How do you think we can make the affected woman realize that she has cancer and needs treatment? How do we improve on this awareness? And the fact that, if you suspect it, you should seek treatment.
This is pertaining to how to increase the awareness in our society as a whole. See, one of the most important people communication network is digital nowadays. So, of course, the step that we are taking today, apart from that, like if you see about polio campaign, how much they campaign, how the polio is eradicated in India. How did they do that? Set up mics in different parts of the country, and there are celebrities came and talk about it, to use digital platforms. I think that is one of the most important, because you see, even in very rural areas also, they might have a radio, they might have a TV, and coming from celebrities, from influential people, sometimes they have more effect. So, and we have an example, we have done it in our country. It's not like we can't.
Polio.
Yeah.
When it comes to polio.
Yeah, when it comes to, we have done it with rigorous campaigning. So this campaigning using digital platforms, training medical medical personnel, not only just doctors, ASHA workers, auxiliary nurses, who percolates the the almost all stratas of the society where we working at corporate hospitals may not be able to reach. If they can make women aware, I think these would be some of the positive steps to make women aware for early detection of cancer. If they have any symptoms, any telltale signs of a possibility of a breast cancer, that they should consult a doctor who will have the network for further reference to an oncologist, establish whether it is at all a cancer or not.
Dr. Roshni, a social media campaign or a influencer campaign is a very good idea. But we also need to think about what we communicate at a level, saying that, finding cancer is important. Is it going to increase fear in people? Because, when you're saying let's detect it early, we must also stress that early on it's curable.
Yes.
Because the treatment is also something that people fear. So what do you think should actually be the messaging? If it's an influencer or otherwise, what should be the messaging?
I think the message should include components of not only that early detection is an important, how to detect one, that is one of the components. The other component, as you mentioned, that how treatments are possible, and that, that the myth we had that initially tuberculosis, people used to die from tuberculosis. You don't see.
And it was a stigma. People
it was a
would
stigma.
avoid them.
Yeah.
People would think we'd get it, and they were discriminated against.
And now we have treatment for it. And people get cured of tuberculosis. So why not cancer? We have treatment for it. Treatments, whatever, people fear the treatment of cancer also. They are very scared of chemotherapy. And people should be aware that, first of all, chemotherapy is not the only modality of treatment now. We have a lot of targeted therapies. We have immunotherapies to incorporate even in early breast cancer nowadays. And all these chemotherapies have also advanced. Whatever side effects do have, we have medicines to control them. We have, all the armamentarium is ready to maintain the quality of life while they are undergoing the treatment for the cancer. So whenever we are talking about awareness, yes, we should not only emphasize on the early detection and how to detect it, but yes, if it is detected, how easily curable it is. I wouldn't say easily, but definitely it is something that, if I would compare the patient living with a cancer, the kind of quality of life they would have, and if she undergoes the treatment for the same, that her quality of life will actually improve.
Okay. Dr. Srinivasa, which is the most effective test suggested to detect the smallest and early breast cancer tumors across age groups?
Please come again.
What is the most effective test which is suggested to detect the smallest and early breast cancer tumors, whatever be the age group?
Yeah, that mammogram is the one which we recommend for early detection, and MRI if earlier age is there, higher risk factors is there, MRI breasts are we have to do. These are the only thing which detect very small lesions only. So most of other tests, when we detect clinically examination and detect, we have the CT scan, other test which will detect this one. Early, which we are not able to detect by clinical examination, is the MRI or the screening mammogram. Mammogram, digital mammograms or diagnostic mammogram, we call it as.
Dr. Srinivasa, can you explain what is the difference between an MRI and a CT scan? Because I think CT scans are still more prevalent around the country. And if I'm a younger person with a higher risk or familial risk, should MRI be my go-to for screening, or should I still do mammogram?
If it is less than 40 years where denser breasts are there, then we are strongly suspecting breast cancer. Yes, MRI is the answer, and usually it is a magnetic source controlled, and it doesn't have exposure to radiation actually as such. So this is, CT scan is like some exposure to radiation will be there. So it is entirely different. So the soft tissue, anything is there, it easily picked up by the MRI scan. So that is the difference actually, MRI and the CT scan actually.
Right. Dr. Roshni, government data shows that the percentage of any kind of breast examination among the reproductive age group of women in our country has not even reached double digits. So how do you see such factors affecting breast cancer numbers in our country in the coming days?
It is all not negative. As I told, at least in the urban population, now breast cancer awareness has become quite a norm. If not a norm, at least it had started increasing, and women are coming forward for their screening programs and surveillances. Rural India, really, it's very difficult to comment right now. But yes, it is not all gray or black. It's improving. We are seeing positive responses. We are seeing women who are coming up, but it needs more rigorous campaigning, awareness campaigns, and it's more effort to see those figures go up.
Yeah, but Dr. Roshni, cancer is still seen as the disease of the aging and the aged. So, people think, oh, this is only for adults, and when should we start talking about this? Like you said, if in a gynae exam, the gynae would help me out, we'd be served better. Everybody would be served better. Now, when should we start talking? Because, what happens is our moms and our grandmoms may be unaware, not interested. They have their own things. They're not paying attention. But younger kids these days are more aware. They're more digitally clued in. Perhaps they can also go and talk to their moms and their grandmoms. So when should we start talking about this?
A very good idea. And yes, you see, as I told you, WHO recommends that you start your self-examination from the age of 25. Very rare to have breast cancer before the age of 5. Before the age, unless you have a hereditary risk, of course. But barring that, the 90% of the breast cancer burden that we see, people should start being aware from the age of 25.
Okay. So you're saying that, talking about this in college and all is also going to be effective?
Definitely.
Okay.
In their workplaces, in their colleges, in the education as well as the professional sectors, to hold programs, to hold awareness campaigns, somewhere we can make use of creating that awareness among our women population.
Right. Dr. Srinivasa, while Dr. Roshni feels that influencer campaigns, social media campaigns, digital campaigns will be very effective because nearly our entire population has mobile phone access, and these days data penetration has also improved a lot. But what about word of mouth? We've done a lot of shows where we have seen that in a village somebody had cancer, she underwent proper treatment in a district away from home, but she came back and she spoke to other women about it. Don't be fearful. Don't think your husband won't love you. Don't think that you will die. So, how important are communities and support groups to ensure that, the awareness increases and the fear goes down?
Yeah, I think we have already that pink cancer survivor group, especially for the breast cancer. So I think these are the self-volunteered people, very well motivated. They spread awareness as well as they give more. Suppose any patients are taking treatment or about to take treatment, they encourage them, they educate them, they share their experiences, and so these are the self-volunteered people are there. Yes, support group. Definitely, we have in our hospital, we have a Pink Hope group where they spread awareness, they conduct camps, and whoever gets treatment, they encourage them. So definitely, this support group definitely is helping. I think it should penetrate more deep into the rural areas. That's what we feel actually.
Dr. Srinivas, this support group is it breast cancer survivors? Is it the hospital staff? How does it work? I mean, like
no, it is not hospital staff. These are the cancer survivor groups. The patient already had a cancer, treated and surviving for longer years. So these are the people affected by the cancer and treated by the cancer. They have it is not the staff of the hospital. It is the self-volunteered public people who are already affected by the cancer. The hospital will only support them in conducting the programs and all. So the one point of contact will be the hospital, like that.
All right. Dr. Roshni, the healthcare infrastructure access may be a limiting point. We have seen some NGOs also have, mammobus. They will take mammograms to the villages. It may not necessarily prove to be very, very successful because, women in villages may not feel very confident or uninhibited about going to a bus. And they go to the bus, they get the exam done, then they may never come up for a follow-up after what happened. Even if you have cancer, you've forgotten about the whole incident. So, do you think there are other technologies that could be more effective in detecting cancer early? We're hearing about liquid biopsies. We're hearing about heat resonance. Your opinion on all of these, or do you think tried and tested mammogram, CDs, these are the ones to go for?
Most of the screening programs as well as treatments, everything is guided by some kind of evidence and data. So right now, talking about liquid biopsy, yes, it is coming up definitely, but it is still a few years to establish that have enough evidence that whether they will be cost effective for screening programs. Whenever we decide for a screening program, we have to look into factors like not only just cost effectiveness, the sensitivity, the specificity. So based on these data points, still now we don't have such evidence that liquid biopsies or any other
upcoming diagnostic
useful
are that okay.
And if you say that this bus mammography thing, that yes, it does happen in our country. So people, women just don't follow up, then they're inhibited. So this is, I think, they have to be guided by someone who lives with them. So as I told before also, like we have ASHA workers. They should be the people because they are living in the village. They're living in the same community. If a woman is guided by a person living in the same community, the trust is more.
More, definitely.
And so will be the follow-up. So they should be trained, they should be more aware so that they can spread that awareness in their own community.
Okay. Dr. Srinivasa, would you like to throw a little light on treatment of early breast cancer as well? Because, some women even fear that bit, having heard about, a relative who underwent chemotherapy 20 years ago and was so miserable and had to get a breast removed, and things are different now, right? Could you tell us how treatment of early breast cancer is and how the quality of life of the patient is?
Yeah, so most of the breast cancer, whether it is stage 1 or up to stage 3, we have to have, the patient has to undergo all the 3 modalities of treatment. That is surgery, chemotherapy, and radiation. So which one is first, it will depends upon the stage. So suppose the patient is in stage 1, so then we subject the patient to surgery, and then it will be followed by the chemotherapy and the radiation. Suppose patient is in stage 3, we subject the patient first to chemotherapy and then surgery and radiation. So apart from that, patient will have the hormone therapy or biological therapy depending upon the receptor status of the, we call it as a ERP or HER2 status. That is the molecular markers we do every breast biopsies actually. So it depends on that. So these are the 3 modalities of treatment, 3 or 4, I think, surgery, radiation, chemotherapy, and hormone therapy depending upon the hormone status. So all the even in early breast cancer or it is locally advanced breast cancer, the patient should undergo all these 3. So coming on to the quality of life, as we told earlier, there is so much refinement in the surgical techniques, in the radiation techniques, as well as the chemotherapy. We have the biological therapy where it will go directly attack only the cancer cells. Normal cells will not get affected. And even we have the very refined chemotherapies where the side effects are very minimal. Actually, we can support them with the other supportive medicine so that they don't get much of the side effects as used to be happening in earlier years. Actually, before 20 years. So vomiting we can control. We can control the infection. So very well established guidelines and medicines are available. So quality of life also is well maintained. Yes, during the chemotherapy, within first or 2 cycles, 5 to 10 days, they have some discomfort of vomiting and loose motion or fever, but it's very well controlled. Most of the patients. That is what the people will not listen to the doctor who is treating hundreds to thousands of patients. They listen to the family members or their relatives where they have seen their only one breast cancer treated in their lifetime. So that is what happening. Most of the patients are coming with fear that we had a family member relative that after giving chemotherapy this has happened, that has happened.
Was very uncomfortable.
Yeah, so they don't listen to. That's what for almost all my patients patients, I recommend you listen to your doctor first. You listen to your doctor who treats hundreds to thousands of patients. Don't listen to your relative where in his lifetime they have seen only one patient. Don't decide your treatment by listening to their relatives. So that is what I recommend most of the patients. And some of the women, they fear more about their hair rather than their health, and we have the counseling. Counseling to avoid that also. To make them more to take the treatment. So that
The
is
hair
what
always
I.
comes back, and
Yeah.
Dr. Roshni,
So we will counsel them so that they should worry about their cancer
and
rather
not
than
really
their.
their health, their hair or their
And
hair
we have
fall.
some more medicines where the hair loss is also less. Biological therapy, immunotherapy doesn't cause hair loss. So depending upon their stages, we can recommend them. We can also accommodate that also actually. So
Dr.
they should.
Roshni, in your practice, how many cases are you able to do breast conservation? Because I think surgery also there has changed, right? Earlier it used to be mastectomy, and now it's different, right?
So this emphasizes the point of early detection. If it's a stage 1 or stage 2, breast cancer surgery is highly possible. So the cosmesis is maintained.
So you retain your breast, you don't lose your breast?
Yeah. It is only a lumpectomy. By keeping a certain margin, the lump is removed. Even the axillary surgery now, less is more. It's not about a whole axillary lymph node dissection, where all the lymph nodes, the 10 lymph nodes or 11 lymph nodes are removed, and the patient ends up developing a lymphedema or a swelling of that particular arm on that side. Now it is all less is more. So even for breast surgeries, we have a breast conservative surgery. For axillary component of the surgery, it is now sentinel lymph node biopsy. So surgery has advanced, the technologies have advanced, and it is supported by a very good pathology. The pathology departments, they give us all the necessary information that how the treatment can be done. Talking about hair loss, females, first of all, we have a cooling cap. We do have it. Not that all hospital facilities will have, but it can help loss of hair to a certain extent. Losing hair is quite a stigma in our society, especially if they lose their hair, they think that people will come to know I have cancer. So cancer is a problem. Losing hair is again a problem.
Even a bigger problem. Everybody comes to know.
Yeah, but we have wigs. We provide it from our own hospitals. Okay, so and it is a temporary thing, as you said. Once the chemotherapy stops, the hair is going to come back. Okay.
Right. Thank you both for joining us today and sharing with us the wealth of your experience. Now, I just want a last word from both of you, because we want this message to go out that early detection is very critical in the treatment of breast cancer. So, Dr. Srinivasa, I'll start with you. Your recommendation to the audience that is watching, not just women, even if men, for their wives, for their sisters, for their mothers, that one piece of advice you'd like to give them, what would it be?
Yeah, so I always I have written 2-3 articles in my own language in magazines, Kannada magazines. So always emphasize the any change in the breast size or anything they detect in the breast, even if it is painless, they should go to their doctor and get tested. So that is the most important. They should not hesitate telling to their family members, either to their lady doctors or whoever there, they should come to the medical attention rather than neglecting it, thinking that this is not cancerous or it is not painful. So that is what the important message I want to give to most of our people actually.
Dr. Roshni, your last word. What would you like to say to everybody watching?
Yeah. So breast cancer is one of those rare cancers in which screening is effective. Not many cancers are there where screening is effective. India has been an example to show that cervical cancer rates have decreased with vaccination and very simple visual examination of the cervix also, apart from pap smear. Breast cancer is one of those cancers in which early detection can change one woman's whole life. It can change the whole quality of life and lifespan. And it is effectively diagnosed, effectively detected using the current surveillance program that are there. So don't hesitate to come up to see a doctor if there is any breast-related problems. There are modalities to treat it, effective modalities with controlled side effects. So don't fear, don't be socially stigmatized. visit your doctor.
All right, Dr. Roshni and Dr. Srinivasa, thank you so much for joining us this evening and talking to us about this very important thing. Creating awareness about breast cancer is important, and also to drill down the message that should you catch it early, you're so much better off. So don't neglect yourself. Thank you both for joining us.
Thank you.
Thank you. Thank you.
With that, we'll wrap up the show today. Do follow us on Facebook to get all the updates on our upcoming programs. This session was supported by Rosh. Now, till we meet again, stay at home, take care, goodbye, and see you soon.